Next, I invite our notable and enthusiastic alumnus, Dr. Athul Sir, Consultant Radiologist, Ma Peslios Medical Mission Hospital, Kochi. He has received the Certificate of Merit, EPOS in European Congress of Radiology.
Good afternoon, everyone. I'm Dr. Athul. First of all, I would like to thank Professor Dr. Devi Minal Madam for giving me this opportunity. So my topic here today is to complete the OSCE in genitourinary tract system. So as you all know, so many questions has been asked from genitourinary tract. This is a vast system including kidneys, ureters, bladder, urethra, adrenal gland, prostate, as well as male external genitalia. So I will try to cover as much questions as possible in this short time. So here this is the first question. So usually in DNB exams, they will give you the image and they will ask short questions like this. The first two questions will be regarding the image for making the diagnosis, and the third and fourth part will be mostly about classifications or interventions or any other treatment management. So here, what is the diagnosis? What is the diagnosis here? So this is a case of genitourinary tuberculosis. So the second part of the question is give specific name for A, B, C and D. So here in this first A, you can see the normal upper pole calyx is in here, but coming down here the calyx appears fuzzy with feathery margins. So this is what? This is moth-eaten calyx. Okay. So coming to the second one, here you can see the renal pelvis is pulled up like this. This is hiked up pelvis. And coming to the third one, here you can see multiple mucosal irregularities in the ureter. So what is the name for this third one? What? Sawtooth ureter. So this is the sawtooth ureter. And the final one is easiest one. Here you are able to see the bladder is filled with the contrast, but it is not distended. It is contracted. So what is this? Yeah, it is thimble bladder. So the diagnosis is genitourinary tuberculosis. And now coming to the treatment for this condition, according to the latest guidelines, so we have to give 6 months of anti-tuberculosis treatment, 2 months of continuous phase, that is 2 months of HRSD, and 2 months of intensive phase, and 4 months of continuous phase with the HRE. So this is according to the latest guideline. And the fourth one is about a classification system. So this investigation is intravenous urogram. So in the fourth part, the examiner will be asking about 3 abnormal nephrograms which we will see and classify it according to Fry and Cattle classification. So according to Fry and Cattle classification, the 3 important abnormal nephrograms are these. First one is immediate, dense and persistent nephrogram. Here you see even after 15 minutes, the right kidney is holding up the contrast. So the level of the density of the contrast will kept unchanged for hours. So that is known as immediate, dense and persistent nephrogram, which is commonly seen in the case of infections like acute tubular necrosis or acute suppurative pyelonephritis. In second one, we can see increasingly dense nephrogram. Here, even after 80 minutes of time, the density of the renal parenchyma is going on increasing. The parenchymal opacification became increasingly dense over a period of time. This is seen when there is failure of excretion of the contrast. It can be either due to some renal stones or any malignancies or any thrombus. So whenever there is a failure of excretion of the contrast, we will get increasingly dense nephrogram. And third one is faint or decreased nephrogram, which we will see in any type of renal failure or any renal artery occlusion or renal transplant rejection. So this completes the first question. The second question is also about the conventional imaging techniques. So sometimes there will be 2 parts for the question. So in this question, in part 1, I am asking you what is this investigation and what is the diagnosis. So what is the investigation? Yeah, excellent. This is ascending ureterogram. Here you are able to see this is the penile urethra and this is the bulbous urethra, and here you are able to see the contrast extravasation. So what is the diagnosis here? This is there is anterior urethral injury. So then you should know about the classification of urethral injuries according to Goldman classification. There are 2 classifications for urethral injury. One is Goldman and the reason one is AAST, just like all other solid organ injuries. So according to Goldman classification, anterior urethral injury comes as grade 5, that was class 5. So And the last part of the question is regarding what is pericatheter urogram and what is the use of pericatheter urogram. I will discuss that later. So coming to the second part of this question, what is the investigation? Here you are able to see the bladder is filled with the contrast. There is stretching and elongation of the prostatic and membranous part of urethra, and the anterior urethra is contrast filled. So you are able to see both the posterior urethra, anterior urethra, bladder as well as bladder base in one image. So this is opposing urethrogram. So and here the diagnosis is there is posterior urethral injury. And I am asking you to classify this injury according to Goldman and AST classification. So coming to the classifications. So earlier we were using Goldman classification. Nowadays also the urologists are asking for Goldman classification only. So 1 to 4 will comprises of the posterior urethral injury, and fifth that is the type 5 is the anterior urethral injury. In type 1 there will be no disruption. There will be only stretching or elongation of the urethra or of the posterior part of urethra. So this injury is type 1 according to Goldman classification. And according to AIST classification, there will be no imaging findings in grade 1. There will be only contusion, so there will be only, clinically there will be blood in the urethral meatus. And whenever there is a stretching injury like this, it is graded as grade 2 according to AIST classification. Rest you can read. And in type 3 there will be partial disruption, and type 4 and 5 comprises of complete disruption. So it is better if you report with the grading or classification when you are reporting AUGs. So the third part of the first question was, what is pericatheter urogram? So this is an investigation commonly done after urethral repair. So what the urologist will do after urethral repair is, they will keep the Foley's in situ. And they want to know whether the healing is complete or not. They will insert a small catheter in the size of a pediatric feeding tube, and they will ingest the contrast, and they will do pericatheter urogram. So if there is no contrast leakage, it means the healing is complete and they are free to remove the Foley's. And if there is any contrast leakage, that means the healing is not complete and they have to wait before removing the Foley's. So that is about the pericatheter urogram. In exams, you may get one question regarding IVU or any of these conventional urethral imagings. So moving forward, now coming to renal infections. So the first part is, this is a case of 54-year-old diabetic woman with a fever, sepsis, who is admitted in ICU. So the first CT image is given. So what is the diagnosis in this case? Yeah, excellent. This is emphysematous pyelonephritis. You are able to see the air pocket within the both renal parenchyma as well as renal pelvis, and some inflammatory fat stranding as well as perirenal facial thickening. What is the name of CT classification for emphysematous pyelonephritis? So the CT classification system is known as Huangson classification, and you should know how to grade this according to Huangson classification. So here you are able to see both kidneys are involved. Whenever both kidneys are involved, that is classified as grade 4. So in grade 1, there will be gas collection within the excretory system, within the renal pelvis only. In grade 2, there will be gas collection within the renal parenchyma. When there is extrarenal extension into the perirenal space or the pararenal space, that is classified as grade 3. And whenever there is bilateral renal involvement or there is an involvement of a solitary kidney, that is classified as grade 4. So you have to read about Huangson classification. And coming to the second part of this question, another diabetic woman with a similar history like weight loss, malaise and low grade fever, a CT image is given. So what is the diagnosis in this condition? Yeah, this is xanthogranulomatous pyelonephritis. What are the predisposing factors for xanthogranulomatous pyelonephritis? Yeah, whenever there is a large obstructing calculi, as well as recurrent renal infections, UTI, diabetes, all these are the predisposing factors for xanthogranulomatous pyelonephritis. What are the most common organisms that you can isolate from these? E. coli as well as Proteus mirabilis. These are the most common organisms that can be isolated from xanthogranulomatous pyelonephritis. So this is about the most common renal infections that are asked in exams. Now coming to renal neoplasms, one question regarding that. This is a CCT abdomen image of a renal tumor. Here I am giving you the size of the mass. The size of the mass is 8 centimeter. which is seen involving the interpolar region as well as lower pole of right kidney. You are able to see this. There is extension into right renal vein, resulting in dilatation of the vein, but there is no invasion of IVC. There is no lymphadenopathy, there is no distant metastasis. So, stage this disease according to AJCC 8th classification. So, what will be the staging when there is a renal mass infiltrating renal vein alone? We will go to that. The second part of the question is, how will you classify this lesion according to the complexity of the lesion with the help of renal nephrometric scoring system? So, questions like this can come. So, you should know the TNM staging as well as renal nephrometric scoring system. So, in TNM staging, T1 and T2 are completely based upon the size of the lesion. If the lesion is less than 4 centimeter in size, it is T1A. If the lesion is between 4 to 7 centimeter in size, it is T1B. If the lesion is between 7 to 10 centimeter, T2A, and if it is more than 10 centimeter, it is T2B. But in this case, we had the size of the lesion was only 8 centimeter, but there was renal vein involvement. So when there is isolated renal vein involvement, we will have to classify it as T3A. T3B and T3C is according to the invasion of inferior vena cava. When there is involvement of inferior vena cava below the diaphragm, that is T3B, and whenever there is an involvement above the level of diaphragm, that is T3C. And T4, the lesion will be invading into the adjacent structure, breaching the Gerota fascia. So, recently the urologists they are asking us to categorize these lesions according to renal nephrometric scoring system. There are 5 components for this renal nephrometric scoring system. The first, the name itself tell you the components. First one is R, that is radius of the lesion. If the radius of the lesion is less than 4 centimeter, we will give 1 point. If it is between 4 to 7 centimeter, we will give 2 points. And if it is more than 7 centimeter, it is 3 points. So, as the lesion size increases, the grade increases. Whether the lesion is endophytic, exophytic or exoendophytic, according to that, as we know, if the lesion is exophytic, it is easy for them to remove the lesion. Whenever it is endophytic, they have to clamp the renal hilar vessels as well as ureter. So, the complexity of the surgery increases. So, if the lesion is entirely endophytic, you will have to give it 3 points. The third factor is the nearness to the collecting system, that is EN. If it is more than 7 mm away from the renal collecting system, you can give 1 point. If it is between 4 to 7 mm, you have to give 2 points. And if it is less than 4 mm, you have to give 3 points. The fourth one is whether anterior or posterior. That is, there is no scoring for that. It is just to mention the location of the tumor. And the fifth one is according to the nearness to the polar lines. This is the one polar line. This is the another polar line. If a lesion is seen between these 2 polar lines, it is a complex lesion, so it will be having 3 points. If it is below one polar line, it will be having 1 point. So, you can go and read. So, we have to classify this lesion according to the renal nephrometric scoring system when you give the report. And if the score is between 4 to 6, it is a low complexity lesion which can be easily removed. If it is between 7 to 9, it is a moderate complexity lesion, and the scores more than 10 will compress it to high complexity lesion. The syndromes in the renal system is also very important. This is a 22-year-old female who was brought with the severe abdominal pain and breathlessness. The CT images are given. So what is the diagnosis? Already this syndrome has been described today. Yeah, excellent, Red-Hope-Duke syndrome. So can you tell me the mutated gene and chromosome for this case? Whenever you read about syndromes for DNP exams, they may ask you about the genes as well as chromosomes. Also, clinical features as well as treatment may be asked. So, what are the characteristic skin lesions seen in this condition? Yeah, you will be able to see follicular adenomas, angiofibromas, etc. And most common renal lesions that you get in this case? Yeah, chromophore cell carcinoma or renal oncocytomas. Excellent. So, here the patient will be having multiple lengths. Spontaneous pneumothorax can be there. Bilateral renal tumors may be present. Usually it may be either chromophore cell renal carcinoma or oncocytoma. Cutaneous manifestations like angiofibroma, perifollicular fibromas can be seen. It is because of the deletion of short arm of chromosome number 17, that is folliculin gene. Now, what is the diagnosis here? What is the syndrome? Yeah, similar questions can ask from tuberous sclerosis. The mutation in tuberous sclerosis, TS1 is 9 and TS2 is 16. Ash leaf macule is the earliest cutaneous manifestation in tuberculosis. And spontaneous rupture. What is the name of the spontaneous rupture of AML in tuberculosis? Yeah, Van der Lecht syndrome. And SIGA is common in foramen of Monroe. What is this syndrome? Yeah, excellent. This is von Hippel-Lindau. In VHL, there won't be any neurocutaneous markers. It is because of the mutation of chromosome 3p. And the most common type of renal cell carcinoma in VHL is clear cell type of renal carcinoma. And sometimes there will be endolymphatic sac tumors also. So this is a 35-year-old male with abdominal pain. So CT showed an incidental adrenal lesion. So MRI was taken for this patient. These are the in-face and opposite-face images. So what is the diagnosis? The lesion appears somewhat iso-intense or hyper-intense in in-face image, and significant signal drop is seen in the opposite face image. So what is the diagnosis? Yeah, this is a fat-containing lesion, usually adrenal adenoma. So you should know the important MR as well as CT quantitative factors that help you to make the diagnosis of adrenal adenoma. So can anyone tell me the name, the important quantitative indices that help you to? Yeah, in CT there are two, absolute washout as well as relative washout. What about MRI? The first question is regarding MRI. So there are two indices. One is signal intensity index. We have to measure the signal intensity of this lesion both in face and out face, and you have to work out with this formula. So if the signal intensity index is more than 16.5, this is suggestive of adenoma. Also another indices is there, adrenal to spleen ratio. You have to measure the just like that. We have to measure the signal intensity of both adrenal gland as well as spleen, and you have to make this calculation. If the value is less than 0.71, which is specific for adrenal adenoma. But it is very easy for us to make a qualitative diagnosis with the help of chemical shift imaging. Because of the fat content, there will be signal drop in the opposite face. These are the two CT indexes. One is absolute washout as well as other is the relative washout. So for calculating this, you have to do a adrenal CT protocol. You have to obtain three sets of image. One non-enhanced image, another is a portal venous image obtained between 65 to 70 seconds. The last one is a 15-minute delayed scan, and you have to make the calculation. If the absolute washout is more than 60%, it is suggestive of adenoma, and if the relative washout is more than 40%, it is suggestive of adenoma. Prostate is also very important. So here this is the first part of this question. A 67-year-old male with elevated PSA levels, MRI prostate shows a lesion here, which is measures about 1.8 centimeter. So before going to the first part, what is this sequence A? What are the important sequences in pyroids? Yeah, this one is T2. Okay, this is T2. B, what is this? Yeah, this is ADC. And C, diffusion weighted imaging. Okay, so here you are able to see a T2 hyperintense lesion showing restricted diffusion in diffusion and ADC images. So what is the diagnosis? Yes, this is a pyroid spoil lesion. This is carcinoma prostate. Okay, so this is pyroid spoil lesion. So this is carcinoma prostate. So you are giving contrast for the same patient, but after some time the patient developed this. What is this? What is this? This is nephrogenic systemic fibrosis. Okay, here you can see there is significant fibrotic contracture of the lymph. So this is nephrogenic systemic fibrosis. Name the chemical process behind this. What is the chemical phenomenon happening behind this? The chemical phenomenon is known as transmetallation. Okay, because of transmetallation, there will be chelation of the ligands. These ligands will precipitate fibrosis, and there will be fibrosis. There is no definite treatment for nephrogenic systemic sclerosis. So better is to avoid contrast. So what is the best cutoff below which you should avoid giving this gadolinium based contrast? What? Whenever the EGFR is less than 30, it is always better to avoid gadolinium based contrast agents. Now coming to scrotal imaging. This is an image of a 7-year-old child with acute onset of scrotal pain. So ultrasound image of the scrotum is given. So what is the diagnosis? What is this clinical sign? And how will you treat this patient? So what is the diagnosis here? Can anyone tell me what is the diagnosis here? Here you are able to see vascularity here, but there is a vascular nodule seen in the upper superior pole of testis. What is this? Excellent. This is torsion of appendix of the testis. You can easily make the diagnosis with the help of history as well as clinical picture. What is this? What is this sign? What color you are seeing here? Yeah, this is the blue dot sign. After the torsion of this appendix of testis, it will become blue in color because of the lack of vascularity, and you will be able to see a blue dot sign. And what is the treatment for this patient? Do we have to take this patient to OT? Just a reassurance as well as analgesics is enough, because this is a non-harmful condition. What happens is this towards the appendix of testis will get detached, and later it will become a scrotolith. It will get calcified, and later it will become a scrotolith. So you don't have to operate this patient. So that is why this is very important. So coming to the last slide. So this is a 31-year-old man who complains of erectile dysfunction. So he was advised to penile Doppler. So this is an image taken after 20 minutes of giving the vasoactive injection. So the first part of the question is, what is the diagnosis? So what is the diagnosis here? Already I have mentioned this is a patient with erectile dysfunction. So you have to be more specific. What is the diagnosis here? So I will go to the second part. Name the vasoactive drug that you use for performing this investigation. Which drug you will inject for this patient? Yeah, excellent, papaverine, or you can give prostaglandin E analogs. Okay. So the third part of the question, how will you differentiate between arteriogenic erectile dysfunction and vaso or veno-occlusive erectile dysfunction? Yeah, excellent. So I will tell you the answers. This is a case of arteriogenic erectile dysfunction, because if you see here, the velocity is less than 20. If you can read, the PSV is just 15.8, and diastolic velocity is 0.91, and the resistive index is 0.944. So what happens in a normal patient is, after you inject papaverine, there will be dilatation of the cavernosal artery, and you will be able to see an increase in diameter of the cavernosal artery. Then you have to perform a Doppler examination, and you have to measure the peak systolic velocity and diastolic velocity as well as the resistive index. So initially what happens is, the peak systolic velocity as well as the end diastolic velocity will start rising. The peak systolic velocity will go above 35 or more. Normally it will go above 40 or 50, and at one stage the end diastolic velocity will start decreasing. It will go less than 5, then it will become 0, and it will show reversal. That will be the pattern in a normal penile Doppler. So here if you see, the peak systolic, even after 20 minutes, the peak systolic velocity is only 15.8, whereas the end diastolic velocity has gone below less than 5, and the resistive index is 0.9. So here this is a case of arteriogenic erectile dysfunction. So the points in favor of arteriogenic erectile dysfunction are, if there is an increase, if the increase in cavernosal artery diameter is less than 75%, it is suggestive of arteriogenic erectile dysfunction. If the PSV is less than 25 centimeter per second, it is suggestive of arteriogenic erectile dysfunction. If you are able to see some focal stenosis, then it is also suggestive of arteriogenic erectile dysfunction. In veno-occlusive disease, you will be able to see a normal PSV value. The end diastolic velocity will be more than 5 centimeter per second, and the RA value will be always less than 0.75. Here the RA value was 0.9, so that RA was normal. So this is how you differentiate between arteriogenic erectile dysfunction as well as veno-occlusive disease. So I think I have covered most of the important OSCEs which has been previously asked. So thank you.
Thank